Hello and welcome to Salem Connections, a show about the people who make Salem work and their stories. I'm Josh Turiel, and I'm hosting the show after 33 years in Salem and 10 years on the City Council. We all talk about news and politics a lot on SATV shows, but we don't talk enough to people with interesting jobs, hobbies, or lives. We have a lot of politicians on the air here, but not enough ordinary people. So most of our guests will be regular people with stories to tell, and I'm looking forward to sharing them with you. Our guest today is a physician who is a relatively new addition to this city, working at North Shore Community Health with our underserved population to deliver family health. Dr. Kristin Darden, welcome to the show.
Thank you. It's good to be here.
Yes. Well, I know it took a while to get you here, but
Sure.
This is absolutely worth it. So I will start with the easiest thing. So tell us about where you started and where you grew up before you came here.
Okay.
And
So if we're going way where I grew up, I'm from southern Missouri. Grew up in the Ozarks and spent a lot of my career or a lot of my education in Missouri, but then upper Midwest and most recently before Salem in St. Louis or outside of St. Louis, Missouri. I came to Salem because I have family here and it was time for a change.
so you're a physician, as I said in the intro. So what drove you to medicine as a career? I know the rest of your family, and they all do pretty diverse things. So
Yeah. So you mentioned growing up in the Ozarks. When you're from a town of 2,000, surrounded by towns smaller than that, the people who go off and go to college and come back are people with medical degrees or law degrees or teach. And science, biology, chemistry, that's what I thought that you did, if that's what you were interested in. And so I went away to college instead of going to medical school. And lucky thing, it turned out to be the right thing. It's not always, but it was the thing that was right for me. Almost to the point of a calling. You know, it's a little cliched. It's a lot cliched. But I can't imagine doing anything else.
was there something in particular that drew you to family medicine as a practice, or?
I get bored easily. No, in all, it's, I thought I was going to do OBGYN and women's health. But I kept getting into rotations. No, I like this. No, I like this. And the reality is the beginning and end of life is so much a part of family medicine that, and I couldn't give that up. It was a chance to get to know people and a chance to become part of a community. And ultimately that becomes a driver for me, is what community am I a part of? What bigger thing can I help grow? And whether that's the community where I work, the community where I live, my children's school, that's what I'm looking for.
And what did your practice look like before you came here? I know you worked in similar, but not quite the same kind of clinic environments.
Actually, so just before I came here, I had taken some time away from a larger, more corporate. It's hard. It's not hard to explain, but it's before moving to Salem, as I'd taken away some time away and had been working in a free clinic. And did that for a couple of years, just volunteering. And I was, I'm very fortunate that I had the ability to do that. But there came a time when I said, I need this not to just be volunteer work. I need this to be my work. I need to be able to do more. I need to be able to see more people. And honestly, I need it to be a job. I still have student loans. I'm 40 years old, and I still have student loans. No, in all honesty. But prior to that, I was in a large not-for-profit, a Catholic organization, probably similar in size to what I think the BI Lahey is here. Affiliated with a larger hospital in the city it's affiliated with, but still has smaller clinics in outlying areas. And so I think that's probably the closest I can explain to what it is as I understand it.
And other than people that you knew up here hassling you, what drew you to Salem?
It was people I know here hassling me to a certain extent.
Okay, I accept some responsibility there.
Yes, you do have some responsibility there. Of course, it's because, sister and her kids were here, and but it was time for a change, and there's a certain. To be frank, I saw the politics of the place I grew up change drastically. And I was starting to see my kids have to stand up for things that we as a family believed in. And if you think about so many of the stories of pandemic denial or vaccine denial, it was becoming too much. And I said, let's change. We don't have to stay here. The COVID-19 pandemic loosened ties for everyone, and in some tragic ways, I think. But the reality was our ties were indeed looser.
So it had a real impact on the community. You were in that.
Oh, absolutely. But it was changing already. And I want to raise my children in a place that's more inclusive, where they have experience of other ideas, and genuinely where they will be challenged, but also where they'll be accepted. And a place like Salem, which feels like it welcomes, it feels like people who are coming to the North Shore, it feels like we land in Salem, and sometimes we move and spread out from there, but this is where we end up. And so it was a place that would have some support systems intact.
So a kind of a follow-up to that is, so you've done from volunteer work and your professional career beforehand, and now you're working community health here. What kind of stuff are you seeing there, and what are some of the differences, and what are some of the similarities?
Well, I mean, medicine's medicine.
Yes.
And good medicine's good medicine. For the reality is, there's things that you just always do. And what doesn't change is that you enter an exam room and you sit down with a person next to you and you make eye contact. And you say hello and you shut up and you listen. And that doesn't change. I grew up in the Ozarks. Poverty is poverty. There are many more resources, but still spread very thinly.
Here versus there?
Here versus there. I don't have to turn an adult with Medicaid away. There's no such thing as an adult with Medicaid. It's just there's just so much disparity in how healthcare dollars are spent. There's a lot. I can do more.
So is that some of that differences in like state eligibility and how they determine things, or?
Without a doubt. And Massachusetts accepted the federal dollars for Medicaid expansion.
And that probably made a large difference. I wonder what kind of difference is that making in outcomes too? I
am not qualified to speak on to that. I just I don't have the numbers. I will say that.
No, all you can give in something like this is what we call anecdata.
My sense is that we're doing. I don't have outcomes data on the population where I was because I wasn't seeing that population.
Yep.
They weren't walking into my clinic. And if they were a point where they were accessing a free clinic, things were...
I mean, that probably says a lot about your outcomes right there.
Right there. So I think outcomes are certainly better here, but in a more affluent place where I was, in practice, there's going to be some disparity.
Sure.
I find that I'm able to help more. I'm challenged in different ways. And I was seeing a lot more of population health. How do we how do we meet a need, again, to get back to that theme of community, because it's very much a part of it. How do we meet a need within the point, for example? How do we make sure that we are doing what we can to address language barriers and cultural barriers? And I am still very much in the learner's seat. Again, it's that point, which I'm doing poorly at the moment, to sit down and shut up and listen and meet the need as expressed by the people who you're serving.
I presume you work some with translation and
almost, yeah. And my Spanish is better than it was. I don't know if I will ever be fluent. I'm working on it though. But yeah,
some of the point is that you are working on it, you know.
Oh, it's delightful.
Yeah, that you're able to do. You're in a position where you're doing the work and you can. So, so a question that comes to me about, again, kind of some of it's disparities in treatment, and some of it is approach. But I know, like, my own experience is from my years with my own physician, and I've been working with him for 30 plus years. I've been going to him since he was fairly new out of practice himself, and I just happened to wind up there. But so a lot of the stuff that I work with him nowadays kind of focuses on the wellness side of things rather than treating issues. You know, he coordinates issues when they happen, but most of his effort is concentrated on trying to keep me doing the things to keep me in health in general. And so I don't have to go in for that. And I wonder, like, how much, and whether in practice in general or in your environment in particular, how much of the practice that you do kind of focuses on the one versus the other?
I would say that that's a shift I've seen career-wide, realistically, that we are getting more and more focused on wellness and prevention, which in family medicine, that's, if there is a specialty to a general, or if there's a specialist point to a general specialty like family medicine, it's prevention.
Okay.
So that when I talk about population health, I think that's the biggest part of it, is that we are working on how are we managing diabetes? Are we checking blood pressures? How do we connect to community services to meet the needs in the home before there's a fall and getting someone into the hospital? And I would say that's probably the majority of the work. Sometimes people, are coming into the clinic farther along in their disease because of access issues, because of 100 different things, but it's still, that's the focus.
Yeah, and so the work is to kind of make up some of the ground that was lost before they come in there, and to get them to a stable, well place, and then try and move them forward. So a theoretical question, I guess, more than anything else, if suddenly a big bag of money were dropped on the floor at your place for you to do things the way you saw fit, what kind of stuff would you try and emphasize? What kind of stuff would you try and change first? Beyond obvious things like physical facilities, where would you try and focus?
Hands. More hands.
More people in general?
More people.
So how I know you guys work your tails off over there. How many people currently are serving the population at your facility? I know North Shore Community Health is in multiple cities.
There's 3 different sites, plus two high school-based sites. Okay. So the clinic at Salem High, and I'm going to get in trouble because I don't remember the name of Peabody's High School.
Peabody High School.
Is it? Yeah. Those clinics are us.
Okay, you operate those. And that's beyond the traditional school nurse stuff.
It's a clinic.
Okay.
I could talk about that. That is.
I would love to hear it.
I will. We'll get there. Healthcare is in crisis right now. There are fewer people doing the work. Some of it is, people who are closer to retirement, that the COVID pandemic just aren't there.
Reshaped everything.
It reshaped everything. And there are people who just aren't there. We lost people in medicine. through illness and then retirement, and just the whole attrition of people saying this is too much for too little, because that big bag of money isn't enough if you can't do the work that you want to do, and if you're constantly being asked to meet an insurmountable need. Everyone's shorthanded. Mm-hmm. There are fewer people doing more work everywhere. But I would say, and I don't think I'm putting words into anyone's mouths to say that community health is in crisis, because the workforce is smaller than it used to be.
How much of that is, I know a number of physicians in other areas. At my gym, there's a number of them that go there, physicians and nurses both. I guess the kind of the natural question thinking about that is, I see a lot of people who still seem to be going into specialties, mm-hmm. or working like directly with hospitals, right. An affiliation, mm-hmm. and what does that leave? I guess I know the like general practitioner, family health seems to be the area that's the most under stress.
I think that's true. So I think this is going to be true in Massachusetts anyway. Mm-hmm. I believe, and again, I don't have the numbers for you, but what I understand is that medical students coming out in mm-hmm. Massachusetts are more likely to go into subspecialties and specialty care rather than primary care across the board compared to other states. But that is true just in general. I make the joke about being 49. 49 years old and still having student loans. And, part of it was there was a financial decision that made sense. Sure. And part of it is that I still have student loans, mm-hmm. And I didn't start, you don't enter the workforce until you're 29 or 30 if you go straight through. And, so it's tough. And to the perceived value because there is a monetary value, the pediatrics is the lowest paid specialty. Family medicine is down there. The numbers jockey around a little bit every time that those surveys are done. It's hard work. Mm-hmm. It's rewarding work. I don't want to do anything else. Mm-hmm. But conveying that to a student, to a learner, that this is awesome, mm-hmm. but it's also hard. And it also hurts sometimes. And, there's grief and there's life. But to circle back around, that's not what you see. And so there's a lot of students who just aren't going into primary care. And then there's so many people who have left it.
Yeah, just going back to just thinking about pediatrics, I would think, yep. given the experience that I just had of having a child who is now 21 years old and is just transitioning out of pediatric care now, as he's wrapping up college, I'm amazed that can be a low-paid specialty because it's such an intense hands-on practice.
It is an intense practice.
And they kind of have to be masters of everything. That's remarkable.
That's
not
primary
in a good
care.
way.
That's primary care.
Yeah.
That's primary care across the board.
Yeah, and primary care, I mean, the way the healthcare model is in this country nowadays, with the HMO system and all, 90% of most people's contact is with their primary care, and they're the person who then sort of shunts them off wherever else is necessary, but it's all filtered through one person, and there's a lot that goes along with that.
And I want to step back and make something very clear, mm-hmm. that I've always made very clear. When it comes to salary and payment and all of those things, I will never complain about what I do, because I have enough to live. Yeah. I have enough to take care of my family. I have enough to do to work I love. But it's realistically, when we look at the arc of how we're going to take care of the American population, especially as it ages, and the workforce that we have with which to do that.
Well, it's
not big enough.
Basically, it's a calling for people, but it's also one where you have, as you already said, you have years of apprenticeship and additional education before you can even start working in the field. And in the meantime, a person's got to eat.
True.
So,
eat a lot of ramen.
So I just.
It's okay.
It's a really difficult model.
Right.
I see, for instance, in my real job, one of the things that I work with is I work with a couple of trade unions, and in those unions, the guys who come to work there, they do the apprenticeship, they learn, but they can be paid a real wage while they're learning, and it's not the wage that they get when they get out, but at least they can go through the education process and be paid to be trained at a reasonable level. That's
going to be that's partially true, but we know this part of healthcare is broken. It's all really difficult right now, and but I think what's more interesting, honestly, is the work that we do get to do. You said you wanted to talk about school health. Yes. We'll get back to that.
Please.
So this is something that when we think about community health, I don't think a lot of people realize that we have 2 clinics in the high schools that are truly clinics. They are overburdened at the moment. So but their role is to do.
So they're just like a real healthcare facility. They're overburdened.
A lot of new arrivals, but they're able to do physicals and immunizations, and with parental permission, able to do sick visits or a strep test or things like that, because they are, in fact, part of North Shore Community Health. But also, they meet a need because there's some counseling available, some therapists on site that can do that, and a student can walk in and say, I need a pregnancy test. I need an STD test. I am sexually active and I'm taking control of this, and what can I do for birth control? And that is something, and if sometimes people who don't have adolescents, and I'm just entering that, and it's becoming more and more, I'm more and more grateful that this is out here as my family enters that stage. A teenager does not need a parent's permission to seek reproductive health. And I think that is very important as they, because we decrease teen pregnancy rates and we decrease STD rates, and the fact that that is there. And they can do long-acting reversible contraception like IUDs and Mirena as shots, birth control pills. And it is someone where a healthcare provider is there, assessing, taking care, and right there, and able to take care of them in the moment. And it's one of the favorite things about my job that exists.
And that's keeping teens healthy and encouraging good outcomes. So that's absolutely the kind of, I look at it as that's the kind of service that's essential. Yeah, because teens are going to make choices regardless of what their parents want them to do or think that they do. They're going to make choices, and they're not necessarily going to be the wisest choices overall, but if they have somebody at their back like that, then they're more likely to have good outcomes.
It's what I used to call, if you're going to be stupid, be smart about it.
Yeah.
Because we all do stupid things. Yep. We all make bad choices, but if we can make good choices around the bad choices, we'll get there to 18, right?
Yeah. We make it that far. And then we kind of move up from there, and hopefully our brains develop
Yeah,
a
we get
little
into
bit.
the mid-20s, and then,
By that time, we're just starting to become humans, and everything else is okay. So we've talked about a lot of stuff that's kind of glum, do you see it? No, it's real, and that's why it's important. Do you see any positive trends kind of emerging in community health care at this level, or at where you are, or in general? Is help on the way, I guess, to a point? Hopefully, some.
That might be a little too optimistic to say is help on the way. We don't know, because we got to look at the pipelines. I will say that the population health, that point of view of how do we keep healthy, how do we look at healthy communities, understanding that the walkability of a community where a person lives, how much green space is there, what pollution is like, and so that we are taking a look at not just the individual in the exam room or the context of the family, but also the context of the city where we live.
Sure.
And that's something
and
that
food insecurity has been a big effort here in this city to try and improve that, and things like the food farm, the expanded pantry, the just opened down the street daily table.
Right.
All these different resources are coming to bear.
And so there's the community piece, looking at climate change as a health issue. Like that's starting to enter, climate change advocacy is starting to enter. The American Academy of Family Practice is addressing that to some extent. So when you say population health, it's not just, the example I gave is what percentage of our patients have their diabetes care taken care of. And that matters, but also, is there adequate food in the community? The other thing I noticed the other day, I can't remember what I was watching, but it said, homelessness is one of the biggest predictors of bad outcomes with diabetes. And that's one of the things we're focusing on assessing, is housing insecurity. And we know that housing inadequacy and housing insecurity has some of the same outcomes for children that homelessness does. So it's not just being unhoused, but also not having an address and not having stability can have those same outcomes. So the fact that we're looking at that bigger picture, and recognizing that the social determinants of health and health disparities are major drivers of the health of the individual, again, within the context of their community, is huge. And I love to see it.
So that's people, I think, seem to be getting more of an idea of the overall context that health exists in.
Right.
I think that's one. I'm going to dare I say that's one positive trend, that I think more people are realizing that health is interconnected to so many other things, and it's not just did you eat right? Did you work out? Did you do this? Okay, you're fine. There's a lot of stuff that goes along with it, and it goes to pollution, to what you're eating, to where can you sleep at night and get a good night's sleep without having to worry about somebody breaking into your tent and stealing what few things you have, or something like that. Those kind of problems.
And sometimes it's even things as simple as, for a kid, how much noise is outside your window.
Yep.
Those sorts of things.
Can you sleep?
All matters. So, and I'm not even going to pretend that we have answers to all of this. It's just that we are finally asking those questions, You can't fix anything until you know the scope of the problem. And we're it seems obvious that these things are problems. It feels like one of those, it's one of those things that clearly, if we could just fix this.
Kind of a light goes on moment for an entire profession.
But the reality is that we're starting to see the data over, what are the data is being gathered, so we can say, okay, what interventions work? I was at a developmental peds conference in March, and I am going to get this statistic wrong. So I am going to just generalize, just gloss it.
Absolutely fine.
There was a direct correlation between decrease in hospitalizations for asthma and other chronic illness when income rose in the home. No other factors changed, just income.
Just income.
Changed about changed whether or not a child was likely to visit the hospital within a certain period of time, and to the extent where that child income credit makes a difference in whether or not a child ends up in the hospital within that year.
Just a tax credit.
Just a tax credit, just cash, just money, makes a difference in what happens with our kids. And that's an example of, if you're not assessing the problem and you're not asking the questions, we don't know what interventions work, but we're starting to find out what may.
So I guess the last real thing that I want to ask about the health side of things is how, I know the approaches have changed, and they're changing a lot and we've learned a lot in the last decade or two. How is this working with the families? Are the families adjusting well to this approach, or
Well, I mean, I
there
think
pushback? Is there
any of us who go to see the doctor, we now know we get the questionnaire that's this long, or the pad with all of the.
Yes.
I think it's the reality. I will say that I have been in spaces where there's suspicion. I've been yelled at for asking the simple screening question of, are there gums in the home? And there are some folks don't take kindly to that particular question. So I think for some folks, some of it may indeed feel intrusive, depending. But then that depends on the relationship, that depends on the community, that depends on the context. And you know, I'm asking because this matter. I'm asking because we know that seatbelts, you know, if I ask about seatbelts, you're more likely to have a seatbelt on in the car. If I ask about smoking, you're more likely to quit smoking. If, you know, if I ask, you know, when was your last dental visit, you are more likely to say, oh, I need to get in to see the dentist. I need to go. I think it's...
So it's a lot of the nudge kind of thing.
It's a lot of the nudge. It's a lot of the reminder. And I think a lot of it is simply, we're used to it. You know, it's part of the healthcare landscape. I can't remember the last time I got pushback on that. Otherwise, then it's long and gets boring. But it's also important. And again, if you take the time to contextualize that, usually it's very well received.
Okay. So I'll steer you away from health and just no, even though that, you know, that's honestly that's fascinating to me, and I've asked you questions about this stuff many a time outside of this place. Spoiler alert, I know her in real life, and
he's the one who made me move here.
One of the people. One of
the reasons. Josh just badgered me till I moved.
I badgered your husband also. True. What has it been like? Just assimilating into a new community, you know, whatever, 1,500 miles away or so from where you grew up, and just
relatively. That's not fair. We're starting to say relatively effortless, and I would say that it really just isn't fair, because there certainly were hiccups in new schools, and but I have watched over the last 2 years both of my children build friendships, settle into Salem Public Schools. I've been able to find my own circles. Chris has found his pinball league and is connecting. Salem has been remarkably easy to join.
Yeah, when I moved here, you know, and decided that this was the place, I kind of said, like, well, it turns out that there was a little hole in my heart that was Salem shaped, and then Salem filled it, you know, the right way.
Yeah, and It's a walkable city. I don't go downtown without recognizing either patients or friends. It feels like a small town, having grown up in one. It has that same sensibility, except I don't have my dad's coworkers watching over me if I'm out doing something. No, there are lots of eyes on the kids, so it feels very comfortable letting them roam.
We went through that and with those ages on my child as well.
It's fantastic.
People would just text me, just saw your kid.
Yeah, and that's all
Your
right.
kid's in the neighborhood.
Don't mind that at all. But it also means there is a lot to do. What I've said since moving is that Salem is a gravity well. We were like, we're going to be in Salem. We're in the greater Boston area. We're going to be in every other weekend. We're going to go do this thing and that thing. And it's not to say that we haven't, but the fact that I can, get up and walk out my front door and be someplace. I can be at the PEM. I can be, I can go get breakfast. I can go for a walk down to the shore in minutes. Mm-hmm. It means we just don't leave as much as we needed to because there's so much here. And we found that's very much a part of our life. How is
as we tape this, we're right in the middle of the October season. So how has that been working out? And it's been spectacularly busy the last couple of weeks.
I don't drive to Peabody for groceries. I drive to Swampscott.
Yep.
And that's what I've discovered. You just don't cross downtown if you can help it. But you can
find
walk.
A route to Market Basket that...
Honestly, walking hasn't made that much of a difference. Mm-hmm. And, we got the front of our house decorated this weekend. It's so we're ready for Halloween. Mm-hmm. And we can, it's miserable to get anywhere by car right now unless you're leaving. And that's okay because we walk most places anyway.
So and the last question that I'll ask is, how has the library been? How's your Little Free Library been holding up the last few weeks?
We have a stockpile because I have a reading habit and a book buying habit, and they don't always meet up.
Well, you buy more books than you read because that's what books are for. Books are for having.
Indeed. Book buying and book reading are different hobbies. Thankfully, I subscribe to both. But we had quite a stockpile. We had a backlog because we were all readers, and we just like it. If it's one, unless it's deeply affecting, it can go on the shelf. But in general, we let them go. The stockpile. It's the first week that we've passed the first full week of October, and that stockpile is gone. So we're gonna have to figure out how to keep the Little Free Library stocked for the next 3 weeks.
Yeah, I have a couple that I have to bring by.
It might be a saver's visit, because books are really cheap there, and it's okay to share.
Mm-hmm. And I will put in a plug for their Little Free Library. They also usually have dog biscuits. So when you're walking your dog by their house, right near Salt and Stall, there are treats for the dogs as well as books for the kids and the families. So
do you know why we did that?
We have dogs rule.
They do, but we
don't have them.
A couple of dog allergies in the family, and 2 kids who really feel the lack. But it doesn't work for us to have dogs. We have cats. But this way we can say hello to puppies as they stop by.
Ditto. I mean, my favorite dog is everybody else's. As much as I love them, I don't have any, and I'm perfectly happy to keep it that way.
Yeah.
And I picked up my cat from the groomer today, and she's very happy. So, see, this wasn't too bad, was it?
Oh, not at all.
Okay. Kristin was a little bit concerned, and hopefully this was a good experience. So thank you very much for coming out. It was a pleasure to have you. I hope I learned some things. I hope the people who watch this, both of them learned some things. And, I will be back in the next few weeks with another episode and another interesting guest that we'll find out about. But for now, thank you. Farewell and good night. And thank you very much to Dr. Kristin Darden for being my guest tonight. So
thanks.
Thank you all.